You know how it usually works in medicine, right? A test leads to a diagnosis, which then leads to a treatment. Simple. But what if the diagnosis is just the beginning? Today, we're diving into rehabilitation medicine, a world where the real work and the real investigation starts after the diagnosis has already been made.
So let's just get right to it. Are medical tests really just refining a diagnosis? I mean, for a lot of specialties, the answer is pretty much yes. But in rehab, a diagnosis isn't the finish line, it's the starting gun. The actual goal is so much bigger, and that changes absolutely everything about how and why we use medical tests. So here's our game plan. First, we'll talk about why the goal of testing is different in rehab. Then, I'm going to introduce you to something called the ICF framework. Think of it as your GPS for a patient's recovery. We'll run through a sort of pre-flight checklist for ordering tests, see it all in action with a spinal cord injury case study, and then we'll wrap up with some really high-yield clinical pearls you can use.
So, what's the big difference here? Well, think of it this way. A lot of medical fields are like sprints. You diagnose the problem, you treat it, and boom, the race is over. Rehab? Rehab is a marathon. The specialist, the physiatrist, isn't just a diagnostician who hands off the baton. No, they're more like the coach, running alongside the patient for the entire journey. The mission here is crystal clear: restore function, minimize disability, and maximize quality of life. And what that means is our tests have to do a lot more work. They're not just for the initial diagnosis. They're for actually quantifying how severe an impairment is, for tracking progress in therapy, for spotting complications before they get out of hand, and even for helping shape a patient's prognosis. Okay, so how on earth do you keep all of this organized? You use a guide, a map, what I like to call a GPS for patient recovery. It's called the ICF framework, and it is absolutely essential to thinking like a rehabilitation specialist. The ICF, that stands for the International Classification of Functioning, Disability, and Health, is a total game changer. It basically reframes disability. It says it's not just some fixed medical problem in a person, but it's this dynamic dance between a person's health and their entire life and environment. It forces us to see the whole person, not just a name on a chart.
So the framework gives us these three interconnected lenses to look through. First, it starts with body functions and structures. This is the raw data, things like nerve integrity or muscle strength. Next, it looks at activities. So how does that impairment affect what a person can actually do, like their ability to walk? And then finally, it zooms way out to participation. How does that limitation affect their ability to engage with life, like returning to a job they love? Our investigations have to give us answers at every single one of these levels. All right, so with that big framework in mind, how do we actually choose the right test in the moment? Well, to make sure every single test is valuable, physiatrists use what I call a pre-flight checklist, 5 core principles that should guide every decision you make. First up, purposefulness. Ask yourself, will the result of this test actually change how I manage this patient? Second, is it patient-centered? We have to think about their comfort, their dignity. Third, is it cost-effective? Fourth, integration. Will this result help the entire team, from physical therapy to social work? And finally, timing. The right test at the wrong time is, well, it's still the wrong test. These rules make sure every investigation we do is targeted and meaningful. Okay, that's enough theory. Let's make this real. We're going to look at a super powerful example: the long-term management of a patient with a spinal cord injury, or SCI. This is where that marathon-style forward-thinking approach really, really shines. Just take a look at this. The SCI diagnosis, that's old news. We're way past that. These tests are all about what comes next. An MRI isn't to look at the old injury. It's to look for new problems at the body structure level, like a fluid-filled cyst called a syringhilia. Annual urodynamics don't just diagnose a neurogenic bladder, they protect the kidneys to preserve that person's health for decades. A DXA scan? That helps prevent a fracture that could completely derail a patient's participation in their work or hobbies. Every single test here is proactive, looking forward, and designed to protect that person's quality of life. Now, speaking of spinal cord injury, I have to pause here for a critical safety alert. Some of these very investigations in patients with an injury at or above the T6 level of the spine can trigger a life-threatening emergency. It's called autonomic dysreflexia. The crucial thing here, and I cannot stress this enough, is preparedness. When AD happens, you have to act fast. Let's say it's triggered by bladder filling during a urodynamic study. Step 1, sit the patient upright immediately. Use gravity to help lower their skyrocketing blood pressure. Step 2, find and remove the trigger. Stop the procedure. And step 3, if their blood pressure stays high, you have to give a fast-acting medication like nifedipine. This protocol isn't a suggestion, it's non-negotiable. All right, to bring it all home, let's do a quick fire round of some actionable clinical pearls. These are some of the key takeaways that come directly from this whole rehab-focused mindset we've been talking about. Pearl number 1, check vitamin D on your rehab patients. I mean it. Deficiency is rampant, mostly from lack of sun exposure, and it directly weakens muscles and bones, which cranks up their fracture risk. The pearl is simple. Check it and treat it. It is one of the easiest, highest impact things you can do. This next one just hammers home that safety alert. Urodynamics are a known trigger for autonomic dysreflexia. This isn't some rare, bizarre event. It's a recognized risk. So the pearl is simple. Always be prepared. Have your protocol and your medications ready to go before you even start the study. And our final pearl today is all about clinical nuance. You are going to see a positive urine culture from a catheterized SCI patient. It's almost a guarantee. But if that patient has zero symptoms, no fever, no change in their spasticity, don't just jump to antibiotics. This is where we remember to treat the patient, not just the lab result. Look for signs of a real systemic infection before you write that prescription. And that brings us right back to where we started, but hopefully with a new lens. The next time you're about to order a test, I want you to ask yourself this question. Is this test for a diagnosis or is it for a life? Is it just about slapping a label on a condition, or is it a tool to restore function, prevent complications, and help someone live the best possible life they can? That shift in thinking, that's the heart of rehabilitation medicine. Thanks for joining me.